If possible, we like to reconstruct before somebody goes to school. Before a child goes to school, we like to reconstruct them. Why? Because babies are really naughty. If you have a scar, they'll call you John with a scar. That's what they call you. So the stigma starts from there. So we'll try and reconstruct as early as possible before they go to school. But unfortunately, only very few people can do band reconstruction.
You can kindly introduce yourself and tell us a bit about your work with the burn patients and victims, and what you are doing as a hospital or doctor to decrease the number of incidences.
Hello.
Yes.
Good afternoon.
Good afternoon.
You can hear me?
Yes, we can.
Thank you very much. I have really been following up the discussions, which are very, very interesting. My name is Dr. Shaban Saidi. I'm a plastic and reconstructive surgeon by profession. I also am a general surgeon. Presently, I'm the vice president of the Kenya Society of Plastic and Reconstructive Surgeons. And also I lead a team as the president of the Burn Society of Kenya. As a reconstructive surgeon, my passion is in burns, to deal with burns, whether in acute form or in reconstructive form. As far as burns is concerned, I may say that I have seen it all. And I really am with Mr. Obum, Jose, who has been a friend of ours for some time. I really feel you, because this is the journey I move with the many clients. It's a difficult journey, and I must give it to them that they are really, really brave to walk with it with their heads up. As a burn surgeon, as a reconstructive surgeon, burns are, I see burns in three ways. In the acute form, when they come in fresh, completely. Then when they are in the ward, in the first part of their treatment, that is trying to get the skin closed, trying to get the burns off. When they go now, I see them when they come in with a bit of complicated contractures. Then there's the long-term complication, as Obum has said, the keloids. So I see my clients in all these forms, and I can say that it's not easy. I'm happy our friend Joki really explained to us how the burn causes this. So the most severe, like the class B, he was talking about the paraffin and the kerosene, causes the more severe injuries and more severe complication and more severe long-term effects, like our friends in the forum. Because, for example, you can imagine paraffin is lighting the wick so that the wick can give us light or can give us the fire. Now, this paraffin is on your skin. It's actually roasting your skin. So that means the burn you get is going to be more deeper. So as a surgeon, what we normally try to see is try and prevent this burn from growing deeper. The deeper it goes, the more complication it is. So that's why we could classify it as either superficial burn or a deep burn. And when it's a deep burn, now involves the other things that are under the skin, the glands that cause us to sweat, the glands that cause our skin to be oily. All these are involved. And also the tissues that make our skin elastic. You know, when we pinch, our skins are elastic. So a deeper burn will affect all that. So meaning that our skin is not going to be elastic, it's going to be like hard. Our skin at that point is not going to sweat. Our skin at that point is not going to be oily. So the first part as surgeons, we try to prevent it from going deeper. If we can do it from the initial stage at this time of first aid, the better, to prevent it from getting deeper. When they come to the hospital, we try to get it to try and close the wound as fast as possible. My two brothers who have talked had very, very extensive burns. the challenge there for the surgeon there was, how do we close these wounds? These gentlemen don't have enough skin on themselves. That's why one of the gentlemen has a passion for skin banking. Skin banking is being practiced everywhere in the world. Where I trained in Asia, skin banking is there. In the acute form, the main thing is to make sure that this person survives. What I remember really with what Obum told us initially, when he went into the hospital, he complained of thirst. He was saying he was feeling thirst. So if he was not given fluids, he would have died actually at that point. So those are the things we watch out as emergency, in the emergency situation. What you call rehydration, because the burns, what they do is they got off your system. They dehydrate you. So the first thing, you can die of dehydration and kidney failure in the initial phase, not the burn itself, but the effect of it. So and really manifested itself with, he was saying, I felt thirsty. So it is important what we teach even now. The patient come, we don't look at the big ones first of all. We like give them fluids to resuscitate them to get them back to normal. Then we take care of pain. Then taking care of pain now, when we start admitting them, we admit them and put them in bed and start dressing the wounds, we do an assessment. I normally do what we call a 14 days assessment, because within 14 days, the burn has told you, I'm very deep, I'm very big, you need to help me heal. Or I'm okay, I'm going to heal on my own. So when we make this decision that this person has to be, this burn has to be helped to be healed, we need to go to the next stage. What do? We need to cover the skin. We need now to put a skin graft. Usually the main source of our skin is your own skin. That is the only way the body cannot reject it. But the problem is, if you get such a big burn like this gentleman have, you don't have the skin. That's why the other gentleman has a passion for the skin bank. We have only one burn center in the whole of Kenya, with a few beds, less than 30, the whole of Kenya. And you can imagine this is the number of severe burns we have. So what we're trying to do is actually to teach the people at the county level, how can you manage severe burns on your own? So as the Burn Society of Kenya, we run something called Emergency Management of Severe Burn course, which is actually targeted to doctors, physicians, and people who treat burns. So we teach them how to manage severe burns, how to be transferred. Suppose there are 20 burns in Mombasa. Even if I transfer them to the burns unit at Kenyatta National Hospital in Nairobi, they'll not be admitted. There's no space. But if we can get these people to be managed at the county level where they are, but that's the thing they're doing, the emergency management of severe burns. With a team from Jose and the rest, we have what we call a Burn Society Forum. We come together with the other stakeholders like the firefighters, the first aiders, the police, the National Disaster Management Units. We come together as a team to see how can we manage burns. And the best way to do is to prevent them from occurring. So we do once a year, we do what you call sensitization. We go to the community and sensitize them on how to prevent burns. And when they occur, what do we do as an emergency? Or what are the first aids, or what are the things to stop? So the firefighters come in handy. They tell them how to really stop the small burns at home, which can become big. When it comes to treatment now, as I said, I've said skin graft, I've said about the people, how you can donate skin. Now there's something called reconstruction. Now when they heal, you heal with scarring, you heal with a joint that doesn't move. If possible, we like to reconstruct before somebody goes to school. Before a child goes to school, we like to reconstruct them. Why? Because babies are really naughty. If you have a scar, they'll call you John with a scar. That's what they call you. So the stigma starts from there. So we'll try and reconstruct as early as possible before they go to school. But unfortunately, only very few people can do burn reconstruction. So we try and do something. What we're trying to do as a burn society, we are trying to get donors to come out so that you can do what you call burn outreaches. Burn outreaches, we go like to a region, look at the patients who have burn issues, scars, contractures, and try and correct them. Let's say within a week, within 2 months, or within a week or 7 days or 10 days, try and see how much can we do. If we go in like 5 surgeons or 6 surgeons to do that within the community. The problem here is just funding, because we have many volunteers who can come up. Many surgeons can come up as volunteers to come and do that. But we need things like transport, accommodation, food, all that. We're trying to work out. Some people are trying. We are trying to reach out to the corporate tree if we can get that moving. Hopefully, God willing, by next year we'll be starting the burns outreach. Then eventually there's the chronic or long-term things. Those things you have to bear with our clients, with our friends. He has talked about the psychological effects. He's talked about the suicidal mission. He's talked about the keloids which he has. Those are the things we need to work together with other people who manage now to manage you as an individual. Burns occurs on your skin, but you are an individual. You have a brain, you have a liver, you have everything. So we have to move with you in such. And we have got a good a support system, but not very adequate. Not very adequate. We can do much in that. We're trying to avoid to address that in the burns forum, but it's not coming about because not very many people are trained